I'm Dr. Nadeem Raja, consultant microbiologist. I'm going to talk briefly about antimicrobial stewardship in a critical care unit. So it's very important to choose a right antibiotic to reduce antimicrobial resistance in the organisms which are prevalent in the critical care unit. So first of all, right diagnosis is very important. For example, right test for right patient at right time, and then interpret the test result at right time, choose right antimicrobial, right dose at right time for right patient. There are three main goals of antimicrobial stewardship. The first one is optimize patient safety. Second one is ensure optimal use of antimicrobials by all providers. The third one, which is most important nowadays, to reduce antimicrobial resistance in the hospital settings as well as in the community, and I would say all over the world. Antimicrobial guidelines vary between critical care units or CCUs. The inclusion of antimicrobials in the antibiotic guidelines, in fact, depends on the prevalence of different microorganisms in that region, plus their antimicrobial susceptibility pattern, availability of different antimicrobials on the hospital formulary, as well as host factors. The main principle of antimicrobial stewardship is appropriate use of antibiotics. I like to mention one study. This study was conducted in the capital city of Pakistan. The researchers reported that 100 patients were included in this study. Empirical antibiotic was started in only 68 patients, and culture were done only in 19% of patients. 30% patient out of these 100 who developed hospital acquired infection did not receive any antibiotic. Irrational use of antimicrobials was found in 86% of patients. In this group, 96.5% mortality was noted. Overall mortality in this study was 83%. The group reported the main reason what they found the irrational use or inappropriate use of antibiotic were of course inappropriate use of antimicrobials. They did not pay attention on drug interactions. For example, antimicrobial interactions between antimicrobials and other medicines, non-adjustment of dose in nephrotoxic drugs, and abundant use of steroids. Most important, not to start antibiotic if there is no infection. So avoid overuse of antibiotics. So we can avoid overuse of antibiotics. We don't start antibiotic if there is no infection. Nowadays, prescribing antibiotics is just like a normal practice all over the world in CCUs. We know antibiotics are life-saving drugs, especially when someone is coming with severe infection. But when there is no infection, these antibiotics also cause harm. So there are so many side effects. Risk of secondary opportunistic infections and many antimicrobials select out other organisms, and if we give unnecessarily antibiotics, then organisms develop resistance against those antibiotics which they are exposed to. Antibiotics cause collateral damage. Antibiotics kill the normal flora of the body. So a vacuum is created, and a vacuum is covered by multi-drug resistant organisms or yeast. I especially like to mention multi-drug resistant organisms, for example, Clostridium difficile, vancomycin resistant enterococci, or ESBL producing organisms. And nowadays, main issue all over the world, carbapenemase producing Enterobacteriaceae. So first of all, ask a question to yourself. Do my patient have infection? If yes, then look for the signs and symptoms of the infection. For example, fever, tachycardia, confusion, raised respiratory rate, and then also look for the laboratory parameters and imaging results, because imaging results will be very helpful. For example, chest x-ray, if there is a consolidation, then the patient is suffering with community acquired pneumonia, or if patient is already in the hospital, then hospital acquired pneumonia. So in the United Kingdom, we use sepsis bundle, so sepsis 6. So the main thing, reduced consciousness, systolic pressure 90 or less than 90, or a drop of 40 from the normal blood pressure, because some patients are hypertensive. Heart rate more than 130 per minute. Respiratory rate equal or more than 25 per minute. Needs oxygenation. Not passed urine in the last 18 hours, or urine output is less than 0.5 milliliter per kilogram per hour. Lactate 2 or more. If patient had a chemotherapy in the last 6 weeks, then choose antibiotic according to the infectious syndrome and administer the antibiotics within the first hour of presentation. So I like to mention basic principles of appropriate use of antimicrobials. Always take cultures before starting antibiotics. Even one dose of antibiotic can inhibit the growth of microorganisms. Then we will not know what is the causative agent and what we are treating with these antibiotics. Do not delay the initiation of antibiotics, because each hour delay increases more than 1% or more than 1% mortality. Take blood cultures from the vein, not from the line. Take blood cultures from the line if there is a suspicion of line sepsis. Always think about starting empirical therapy or a narrow spectrum if we are not sure. So what is the causative agent? For example, if someone is presenting with abdominal sepsis, so we wouldn't know. So what is the causative agent? So we need to start broad spectrum antibiotic or cover all possible causative agents, for example, gram-positive organisms, gram-negative organisms, as well as anaerobes. And if we know We can use our clinical judgment, and if we know the causative agent is, for example, a Staphylococcus aureus or Streptococcus group A, then we can start narrow spectrum and definitive therapy on the basis of our clinical judgment. Appropriate dose is very important because underdose always contribute in the antimicrobial resistance. Use monotherapy wherever is possible. I like to mention shorter courses of antibiotics are as useful as long courses of antibiotics. For example, if we are treating urinary tract infection in females, so 3-day uncomplicated urinary tract infection, 3 days would be enough, rather giving 14 days. So these are short courses are always good. And do antimicrobial levels if we are using nephrotoxic, ototoxic drugs or other drugs, so where we need to achieve a therapeutic range. Adhere with infection control policies. It is also very important to combat antimicrobial resistance issue. So what are the common causes? What are the common errors in the critical care units? So delay in the administration of antimicrobials, especially in the severe sepsis, or giving antibiotics before taking cultures, and blood culture are not taken aseptically, or less volume of blood in the blood culture bottle. And another important error in the CCUs, prolonged courses of antibiotics. Quick changes of antibiotics. I have also noticed one day patient is on comoxiclav, in the evening they think that antibiotic is not working, so they change to tazocin, and following day the patient is on meropenem. This is not a useful or not a good practice, because antibiotics need time to be effective and kill microorganisms. So we usually see the response, good response, sort of 48 hours. The other common error is inadequate dose. So dose should be right dose as per the antimicrobial guidelines. Then poor choice of antibiotics. Sometimes we do not monitor the nephrotoxic drugs, or for example, if we need to monitor the levels to achieve the therapeutic range. Failure to de-escalate or start narrow spectrum or switch from intravenous to oral once patient has clinically improved or the culture results are available. So how to determine initial choice of antibiotics? This is very important. So always take travel history. For example, if somebody visited endemic region of any disease, for example, leptospirosis or Lyme disease, always check the occupational history. So what is the occupation of the patient? For example, if patient is butcher or working in a butchery, so that patient is at risk of Coxiella burnetii infection. If patient is a fisherman, so at risk of suffering with Vibrio vulnificus. Farmers, usually they suffer with brucella because they are exposed to brucella. And it's so very important to take recreational history. For example, if someone is using recreational drugs, intravenous drug user, so look for the signs of endocarditis in that patient. If patient has got pets at home or exposed to animals, then maybe psittacosis or toxoplasmosis. Walking in the bush, tick-borne disease, alcoholism. So patients with alcohol excess, they suffer with pneumococcal infection, they suffer with Vibrio infection. And also check for the recent use of antibiotics, whether those antibiotics were effective or antibiotic did not work, or did it select out other organisms. For example, if we give quinolones, so quinolones select out enterococci, so then enterococci is isolated from different clinical specimens. And also think about starting empirical versus definitive treatment. So if we start empirical treatment, then rationalize as soon as patient has improved and the culture results are available. So it's very important, it's really urgent to give antimicrobials, as I mentioned earlier, within the first hours, because it reduces the mortality and we achieve a good outcome. Do the right cultures, so the cultures should be reliable, correct specimen. Also think about the polymicrobial infections. For example, abscesses are polymicrobial in nature. Consider host factors, for example, renal disease, liver impairment, and also age. Adjust dose according to the age, body weight, renal status, etc. And also check for the genetic variation. For example, if someone is suffering with G6PD deficiency, then they suffer with hemolysis after receiving nitrofurantoin or dapsone. It's not wise to give teratogenesis drug which causes teratogenesis, for example, tetracycline in pregnant ladies. Check the immune status of the patient, whether patient is immunocompetent, immunocompromised, on steroids, suffering with solid organ disease or hematological malignancy, or received recently chemotherapy. So choose antibiotic. If someone is suffering with, presenting with neutropenic sepsis, then start antibiotic according to the neutropenic sepsis protocol. So also think about the causative agents of the infectious syndrome. For example, if someone is presenting with central nervous system infection, meningitis, bacterial meningitis, so what are the common causative agents? Whether this patient is suffering with meningococci, pneumococci, Haemophilus influenzae, or some other organism, listeria, so then cover the all causative agents appropriately. It is most important thing. Think about whether the organism is intracellular or extracellular. For example, in Salmonella infection, we do not give gentamicin because it does not penetrate into the tissues and it does not kill Salmonella. If the patient is suffering with osteomyelitis or discitis, so we will choose antibiotic which can penetrate into the bone tissues. So it is very important also to control the source of infection. Get rid of the source of infection, then antibiotics will work effectively, quickly, and we will see rapid response to antimicrobials in patient. So as I mentioned earlier about the duration is very important. So when there is no infection, stop antibiotics. Do not give prolonged courses. Choose right antibiotic. And also consider about the toxicity of different drugs. Choose accordingly and wisely. So site penetration is very important. For example, if someone is presenting with central nervous system infection, so we should choose antibiotics which can cross blood-brain barrier and reach to the brain and kill the microorganisms which are causing meningitis. So sometimes we also give antibiotics for synergistic effect. For example, if someone is suffering with a bacterial streptococcal endocarditis, so we give beta-lactam drugs which destroy the cell membrane of the microorganism, and gentamicin as a synergist for the synergistic effect, and it enters into the organism, and then we are able to cure the endocarditis. So now I am going to give a few examples. So what we are doing in the United Kingdom about if someone is presenting with sepsis of unknown origin, so we don't know whether it is a gram-negative organism sepsis, it is a gram-positive organism sepsis, or it is anaerobic infection, or it is due to yeast. So if bacterial, then we give broad spectrum after taking the cultures. For example, comoxiclav, piperacillin tazobactam plus gentamicin or aminoglycosides. So either one, comoxiclav or piperacillin tazobactam plus aminoglycosides. If patient is allergic to penicillin, then we choose alternate antibiotics. For example, vancomycin or teicoplanin plus aztreonam plus aminoglycosides, or cotrimoxazole plus aminoglycosides. If there is a line infection, we will add vancomycin. So it depends on the choice of different antibiotics and the causative agents. And the other example is community acquired pneumonia. So first of all, we need to check the CURB score. So in order to cover gram-positive organism, because it could be streptococci, could be Haemophilus influenzae, so atypical microorganisms, for example, chlamydia, legionella. So we choose antibiotics which cover almost all causative agents. So first line, as I mentioned earlier, comoxiclav. If we think that this patient is suffering with or already underlying illness is bronchiectasis, so we need to cover Pseudomonas with piperacillin tazobactam. We also add doxycycline or macrolides to cover atypical organisms. If someone is suffering with neutropenic sepsis, so tazocin or meropenem. So I would like to give another example of hospital-acquired pneumonia or ventilator-associated pneumonia. So it's very important because gram-negative organisms are prevalent in the critical care unit settings. So if it's a hospital-acquired pneumonia, we can start with comoxiclav. If ventilator-associated pneumonia, or we suspect that Pseudomonas aeruginosa is causing infection, or Pseudomonas aeruginosa is prevalent in the hospital settings, then we can start with tazocin. If Serratia or some other organisms are prevalent, so, and provided they are sensitive, so we can start cotrimoxazole plus aminoglycoside. So aminoglycoside we can add if there is a really advantage of adding second agent. If, for example, someone aspirated in the critical care unit, so either we can give amoxicillin clavulanic acid or piperacillin tazobactam because they also cover anaerobic organisms, or we can give amoxicillin metronidazole or cotrimoxazole plus metronidazole, and if needed we can add aminoglycoside. So it all depends on the prevalence of microorganisms, and especially in aspiration we need to cover anaerobes. It is very important. If someone is presenting with abdominal infection, for example, acute pancreatitis, biliary sepsis, diverticular disease, diverticular abscess, then we can start comoxiclav or tazocin or amoxicillin metronidazole plus gentamicin, because we need to cover gut flora. So in the gut, gram-positive cocci, gram-negative organism, a lot of anaerobes also reside in the gut, human gut. So we need to, sometimes we also use ciprofloxacin metronidazole if patient is allergic to penicillin. So we can add aminoglycoside if needed, or vancomycin plus quinolones plus metronidazole. So different regimes. Even we can give quinolones, levofloxacin, moxifloxacin in community acquired pneumonia as well, or vancomycin plus ciprofloxacin. So here we can use vancomycin, ciprofloxacin, and metronidazole, and then rationalize once we know the causative agent of the abdominal sepsis. And if there is suspicion of any yeast infection, especially after the abdominal surgery or critical care unit, because of lines, because patient receive total parenteral nutrition, so there are so many risk factors, then we can according to the clinical condition or the isolated yeast, candida, different types of candida, so we can either start fluconazole. It also depends on the severity of the infection, or echinocandins or amphotericin, liposomal amphotericin or amphotericin B. So it is always debatable to use antimicrobials in pancreatitis, but it is recommended if necrosis is more than 30, then use antimicrobials to treat pancreatitis. Or sometime if there is a pseudocyst that is infected, yes, then also treat and start antibiotics. So we can use different antimicrobials, piperacillin, tazobactam, some even use meropenem, and also we need to cover yeast infection as well. So Clostridium difficile, another important hospital-acquired or healthcare-associated infection. So in England now, the first line is oral vancomycin, but majority of the trust are still using metronidazole as a first line. And if metronidazole failed, then they use oral vancomycin. And in recurrence of Clostridium difficile infection, fidaxomicin is used. So necrotizing fasciitis is a real emergency. surgical debridement or surgical intervention is very important. So always start with broad spectrum antibiotics, and also use uh, antibiotics which can neutralize the toxins and also kill the toxin producing organisms. So normally tazocin, clindamycin plus minus gentamicin. So this regime is very important. Or if patient is allergic, then meropenem, clindamycin and gentamicin plus minus gentamicin. If we know, for example, Streptococcus group A is causing necrotizing fasciitis, then we can start definitive therapy for Streptococcus group A infection. If a patient is, if there is a MRSA infection, then we can start anti-MRSA antibiotic, for example, vancomycin. So I like to summarize my today's talk. So the mainstay of antimicrobial stewardship is right diagnosis, right antibiotics, right dose at right time for right patient. Choose antibiotics wisely according to the infection syndrome. Take cultures before starting antibiotics. Review antibiotics after 48 hours or when culture results are available or patient has improved clinically. Then start definitive therapy. Review or stop date of antibiotics that should be included, and stop antibiotic when there is no infection. Thank you very much for watching this video.